Olá a todos, estamos aqui com o Dr. Jim Hu, chefe de urologia da Cornell, e que participou agora na plenária de um debate sobre biópsias transperineais e transretais de próstata. Então vamos conversar um pouquinho com o Jim. Jim, so thank you so much for your time. It was a wonderful debate that you just joined right now. And if you could please tell our fellow Brazilian urologists about what you think about the state-of-the-art of prostate biopsies, if we're going to change to transperineal, if it's transrectal, what are your thoughts on that?
Sure. Oh, thank you. Should I hold it? Okay, thank you. So it's wonderful to reconnect with you, Fernando. In the session today, I think the current environment in the United States is that there's pressure academically, for example, from Europe, where there's a lot more enthusiasm for the transperineal approach. In the US, I think the concerns, whether right or wrong, are that the transperineal approach takes longer to do under local anesthesia. Most people who do transperineal like to use the precision point device. That device costs $200 per use. It's a disposable device. And currently, the way that health insurance is reimbursed in the United States, they reimburse the urologist the same amount, whether it's done transperineal versus transrectal. And so I think from a business standpoint, and again, I'm not trying to portray us as capitalists, but truthfully, I think until there's strong evidence out there that the transperineal approach is superior, it's going to be hard to change practices based on the fact that it takes the urologist longer, they're less efficient, and the costs are higher. And so of course, Badar, one of the panelists, has his randomized control trial that he's presenting Sunday as a late-breaking abstract. We also have 2 randomized control trials funded by the National Cancer Institute, as well as the Patient-Centered Outcomes Institute, that are looking at the primary outcome of infection, comparing transrectal versus transperineal biopsy. I think the other interesting points that we made, at least during the session, if you look in the United States, for example, for the type of prophylaxis that's used, and we look at Medicare data, which is the healthcare for men aged 65 years and older for the majority of Americans, we see that a targeted biopsy or rectal swab is performed in less than 2% of men prior to a biopsy. So it tells you that most of us in the United States are doing augmented prophylaxis. During the session, one of the things that I pointed out, for example, at our hospital, New York Presbyterian, when we looked at the antibiograms, for example, for fluoroquinolone, the resistance is about 27%. This is looking at urine cultures throughout the health system as well as in the emergency room. Then on top of when you look at the other sensitivities to other bacteria or other antibiotics, for example, if you have fluoroquinolone resistance, that is, in the 27% of men who have fluoroquinolone resistance, what is the susceptibility rates to the first, second, third generation cephalosporins, the aminoglycosides, Bactrim, and others? We see that there's still 25 to 30% resistance. So that is, if you have a resistant organism already to fluoroquinolone, there's also a 25 to 30% chance that you also have resistance to the antibiotics that you would use for augmented prophylaxis. And so it just shows you that again, the resistance patterns are increasing because more and more of us are using augmented prophylaxis or multiple agents. I think there's probably widespread of use of prophylaxis beyond 24 hours. That's also going to generate more resistance. On the other hand, a targeted prophylaxis, of course, there's more work for the physician, right, to check what the culture is, to change the antibiotic if there is resistance from a fluoroquinolone. So there's also inconveniences or taking the urologist's time to do those things. So again, and in that way, I think transperineal biopsy gets rid of that, because I know in Badar's study and our study, there is no prophylaxis for transperineal biopsy. So not to worry about calling in the prescription to the pharmacy, checking the prophylaxis, I think is a great thing. I think obviously it has no impact on resistance patterns because you're not prescribing antibiotics prior to a transperineal biopsy. But the learning curve, the inefficiency, the greater cost, those are the issues I think that are challenges for us to adopt it, at least in the United States.
Great. So probably some changes in the horizon, but still you have to wait for data, and there's no wrong practice right now. It's more of a choice of the urologist and the patient.
Absolutely. I'll just say that the randomized control trials that are ongoing, for example, Bader's trial, he's using augmented prophylaxis. In our studies, we're using targeted prophylaxis. And so I think when these trials mature, it'll be a nice contrast because we are using the three different strategies to reduce the risk of infection. That is transperineal, augmented prophylaxis in his studies, and then targeted prophylaxis in ours.
Great. Again, thank you so much, Jim. It was great to see you again.
Great to see you always. Thank you for the opportunity.
Bye.
All right. Thanks.